Thank you for that introduction. Good afternoon, and thank you for coming in and listening to our lectures from the Harvard faculty as well as our visiting faculty on the update of anesthesiology 2022. This afternoon, I'd like to talk about the neurotoxicity in infants and the impact of anesthetic drugs on the neurodevelopment of the infants and the current status of the ongoing work in this area. As far as disclosures, I have no financial relationships to disclose. And at the conclusion of this activity, I hope to describe some of the current and ongoing clinical research on the impact of anesthetic drugs in infants and children. This has been an ongoing concern in our specialty for almost 20 years. And this has been highlighted by a recent editorial by prominent anesthesiologists in our field, Andrew Davison and Laszlo Vutskis, where they're looking for the phenomenon or the actual description of neurodevelopmental changes after general anesthesia in our pediatric patients. And certainly this is a cause of concern for those, particularly those who are working on basic science research. Because as we've known for many years, the laboratory has substantially shown that exposure to anesthetic drugs causes diminishment of neuronal process, particularly in the area of neurodevelopment. And it occurs at all levels, both at neural activity, at the intracellular level, and the extracellular level. And certainly, this can lead to changes in the neurodevelopment of the laboratory animals. But the issue here is, can we extrapolate what we see in the laboratory to what we actually do in the clinics and in operating rooms? And certainly there are two distinct environments where we anesthetize our experimental animals and as well as anesthetize our patients. And there are true differences in the genetic makeup as well as the environment in these different species. As I've mentioned before, the issue is whether or not anesthetic drugs causes changes. And so that is the environment itself, that the drug exposure to drugs causes changes to the brain, particularly in the realms of neuropsychology. However, there are also issues involved with what the patient brings to the operating room or in the ICUs, where genes expressions that lead to congenital anomalies may cause some neurodevelopmental issues. And again, also the epigenetics, there's the interaction of the environment to gene expression, and also development can also impact how the brain develops during this time. A good example of this is this work by the Pediatric Anesthesia, Cardiac Anesthesia Collaborative, where the investigators in this group, led by Chris Homsey here at Harvard Medical School, along with his colleagues in the Department of Cardiology here and other institutions in the United States, looked at gene expression of various congenital anomalies, particularly those with cardiac issues. And certainly they were able to link de novo mutations that were consistent among those with congenital heart disease as well as those who develop neurocognitive disorders, showing that indeed there's commingling of these genes, and perhaps the issue of congenital anomalies can lead to neurodevelopmental disorders. So this is not what the drugs or the surgery does to the patients. It's actually what the genes do to the patients, leading to neurodevelopmental disorders. Furthermore, subject over in Belgium looked at neonatal surgery for non-cardiac disease in congenital anomaly patients, and found that many of these patients with congenital anomalies had de novo lesions in their brain that can potentially develop into neurocognitive disorders. So indeed, again, these non-cardiac congenital anomalies can predispose these patients to neurocognitive problems afterwards. And this has certainly been shown by several retrospective studies in large cohorts of patients. And exposure to the anesthetic of the patient and the fetus, for that matter, to the anesthetic drugs may impact various neurodevelopmental processes, such as genesis of neurons and glia, axonal and dendrite outgrowth. That is, as the neurons grow, it forms these dendrites and axons that communicate with other neurons, synapse formation, and myelination to provide solid interneuronal communication. However, there's an ongoing process that's just normal of pruning of excess neurons, such as programmed cell death, elimination of axons and dendrites, and synapse elimination. That is where redundant neurons and other neuronal structures are eliminated because they're not useful. And this occurs throughout the lifespan of the patient. So therefore, the implication is changes in environment during this period can impact these processes that both promote neural growth and also decrease and prune neuronal growth. And also there's windows of plasticity in brain development. Currently, most of the work is done in infants and toddlers, where the primarily domain of neuronal development is sensory. And certainly exposure to anesthetic drugs and surgery during this period can lead to sensory changes. However, during development, particularly in the adolescent age, as well as in older teenagers and young adults, there are other domains that may be impacted. Motor and language development may be impacted to children exposed to anesthetic drugs or changes in the operating room as well as the ICU. And higher cognition, executive order may be impacted in older patients. So again, you have to look at the lifespan of the patient and see where in fact they're vulnerable to these changes in the neuronal development. The first study that showed that indeed there is some association between exposure to anesthetic drugs and learning disabilities is this retrospective study by Bob Wilder and his colleagues at the Mayo Clinic, where they show that early exposure to anesthesia led to increase in learning disabilities. As you can see here in the dotted line and the thin line, that is no anesthetic exposure or one anesthetic exposure, there was really no difference in the incidence of learning disability diagnosis. However, when these patients were exposed to multiple bouts of surgery and anesthesia, it increased the incidence of learning disabilities almost threefold. So therefore, they will demonstrate that indeed exposure to the operative environment and may indeed cause these increases in learning disabilities, showing that there may be a clue to the fact that there is an interaction between the two. Furthermore, they've been able to develop this concept and apply it to the incidence of attention deficit hyperactivity disorder, where indeed they have very similar curves where multiple exposures to anesthetic drugs led to behaviors that are consistent with ADHD. However, there are studies as well that show there is no difference in whether or not patients are exposed to anesthetic. In this case, you had monozygotic twin pairs, those who were exposed before age 3 and then again at age 3 to 12 years, and showed that exposure before age 3 is associated with significantly lower educational achievements in scores and more cognitive problems. However, the non-exposed twin did not differ from the exposed twin who had the surgery. So therefore, it may be the fact that it's not the exposure to anesthetics itself, but it's something that's more aligned with the patient's genetic makeup. In another study by Tom Hansen from Denmark, he looked at a cohort of 2,500 patients undergoing inguinal hernia repair and compared that to a birth cohort of almost 15,000 patients at the end of the last century. He looked at academic performance in 9th grade and found that the adjusted hazard ratio of increased behavioral problems was not significantly different from those who were not exposed. However, he was able to show also that indeed the males scored poorly compared to the female cohorts in the study, which shows indeed the notion that girls at this age were much smarter than the boys. And that's certainly something that experienced myself both personally and with my own children. And then there have been large database examinations of the incidence of surgery, early life, and child development. And this is work done by James O'Leary, and a very similar study was published by Ruth Graham from Calgary. This study from James is from Toronto and showed that surgery before 2 years of age, any surgery before 2 years of age, had a slight increased vulnerability to low scores for this primary school entry examination. However, it was not statistically significant and did not change according to the duration of the surgery. So indeed, there was a slight increase, but not clinically significant. And certainly Ruth Graham's work from a very similar database showed similar findings. Another large study by Pia Glantz from Sweden looked at all operations at an early age and looked at scores for entry into the military and found that all operations did not change their scores. However, those that impacted surgery on sensory organs such as the eyes as well as the ears, hearing, and vision may have caused the scores to be decreased somewhat. But overall, there was no increased significance of disability or lower scores and educational attainment at high school age. However, you have to look at other studies that show there is a change. This is a study by Banerjee from St. Jude's Children's Hospital in Tennessee, looking at over 200 patients who had leukemia and underwent general anesthesia exposures for radiation therapy and various diagnostic and therapeutic procedures. And they found that indeed that there was increased global neural impairment when you had increasing doses of propofol, thereby saying that indeed that the high exposure to propofol over time caused significant increase in global neurocognitive impairment. They found a trend also for fentanyl showing that indeed these changes may have an impact on neurodevelopment. But you have to realize the more frequently you're requiring this therapy, the sicker you are and the more severe your condition is. So again, it's hard to differentiate between what the disease process is doing to neurocognitive outcomes versus the amount of drug given to these patients. And a study from Bristol in the UK looked at even more granular examinations of neurodevelopmental outcomes in this longitudinal study, and found that there was a slight decrement in motor skills in those who had a single exposure to anesthetic drugs. But then again, it doesn't deviate very far from the norm. So therefore, they found that this was clinically insignificant. But again, the more granular the study are, you may see some changes. So a survey of all these retrospective studies show that a wide range of no differences at all in the twin study up to changes of a hazard ratio of 2.55 in the RAIN study by Caleb Ng using a group in Australia. So it's all over the place, but again, these are retrospective studies, and it really doesn't address the direct issue of whether or not anesthetic drugs have an impact of anesthetic on neurodevelopment. Now let's look at some prospective studies, and this is the PANDA study that came out of Lena's son and Caleb Ng's group in Colombia, where they looked at the association between a single general anesthetic before 3 years and neurocognitive outcomes, and found that they had no changes or no significant differences in those patients who exposed to anesthetic to their cohorts who were siblings. Another study by the Mayo Clinic group looking at prospectively looking at some of their patients found that in the granular tests secondary outcomes, they found fine processing speed as well as fine motor abilities were somewhat decreased in multiply exposed patients. However, the other domains did not differ. So the primary domains were not impacted. So the primary outcome of intelligence quotients did not differ, but it's the more granular processes such as processing speed as well as fine motor abilities were impacted by that, but it's not quite significantly. So the more granular the tests are, the more differences you'll see. So they conclude that anesthetic exposure before age 3 was not associated with deficits in general intelligence, but some secondary outcomes had some trend to some decrement in performance. Now, in a true prospective randomized controlled study, our group, along with our collaborators from Europe as well as Eurasia, looked at the impact of a short duration anesthetic, that is inguinal hernia repair, on psychomotor assessments both at 2 and 5 years of age. And here we compared general anesthesia with sevoflurane versus an awake regional anesthesia, primarily a spinal anesthesia, in this international cohort of patients. And we found after 2 years, there was no difference in the intellectual examinations of these patients. And in a follow-up study to that, we looked at the neurodevelopment outcome using WIPSI at 5 years of age. We found very similar findings to the previous one, where there was really no difference between the spinal versus the general anesthetic group. Again, reassuring most of our colleagues that indeed a short duration anesthetic on a healthy patient with inguinal hernia will not impact neurodevelopmental outcome both at 2 and 5 years of age. So given this data, our colleagues in Europe put out this guidance and statement saying that indeed it's well-established anesthetic techniques delivered by trained and experienced staff in pediatric anesthesia supported by the necessary and clinical organizations, essential factors for delivery of well-tolerated anesthesia and sedation in children. And therefore, they feel that the cutoff age of 3 years warranted by the FDA at that time was not currently supported by the evidence from these human studies that I've thus far talked about. So what's in the horizon? Certainly this work is still ongoing, and again, we see many studies are coming out, particularly in identifying biomarkers in these patients. As we know, the primary psychometric gauges that we have are the Bailey as well as the WIPSI test scores. However, as you see with the development with the publication of the Avon study, they're using more refined and granular evaluation of neurodevelopmental outcomes in these patients. So we'll see more and more of those studies coming out, seeing and determining whether or not these fine motor movements that the Mayo Clinic talked about is indeed impacted by the exposure to surgery and anesthesia. There are issues there are other applications of neurophysiological testing, that is testing that we have as very similar to what we have as in intraoperative neuromonitoring, where we can actually gauge the changes in these patients given the impact of anesthetics and surgery. And there are some studies that are now in review that use some of these very sophisticated neurophysiologic testing protocols. And certainly, chemical biomarkers is in the horizon. And we have some preliminary data from our own work here at Harvard Medical School, where we measured tau levels in patients undergoing surgery and found that tau, which is a marker for neurodegeneration in Alzheimer's patients, is indeed increased in the urine and serum of some of the children that we exposed to anesthetic drugs. And then certainly it may be a marker. Again, it's important that we be able to show that these changes in tau in tau, particularly elevations in tau, correlate with changes in neurodevelopmental outcomes. So that's something that's still in a very preliminary stage and something we've been heavily investigating. What can we do now and when you take care of your next pediatric patient? Certainly minimizing coexisting conditions. As I mentioned before, congenital anomalies play a huge role in neurodevelopmental outcomes, and there are many studies that show that indeed it has a huge impact. Pre-existing disease, whether it be chronic or acute, particularly acute diseases such as cardiopulmonary insults that may occur during the surgery itself or during the perioperative period will impact that. And along those lines, physiological derangements that occur during surgery can cause problems as well. And specifically noting hypotension and hypo or hypercapnia can impact cerebral perfusion. And certainly many of us are starting to use so-called neuroprotective strategy in anesthetizing these patients. My lab here has shown that dexmedetomidine in rat models produce cell signaling proteins that favor cell survival and can be somewhat neuroprotective. And that's been shown in several studies, particularly by Mervyn Mays' group at UCSF, where they found that sevoflurane can indeed, dexmedetomidine can indeed reverse the injury that isoflurane causes in the rat models. Whether or not this is pertinent in the operating room as we anesthetize our patients, we'll find out. But there's an ongoing study now, the T-REX study headed by Dean Andropoulos and his group at Texas Children's Hospital that's looking at the impact of using dexmedetomidine as the primary anesthetic. So just to round up this talk, certainly we have to look up beyond anesthetic toxicity. And this is a nice review by my colleague Marianne McCann, Jenny Lee at Hopkins, and Terry Ender from the Brigham and Women's Hospital. Terry is a neonatologist there, looking at what causes neurological injury in this case neonates, but we can generalize it to pediatric patients. And certainly that these processes can be modifiable, including preventing or mitigating intraoperative hypotension, hypocapnia, hyperoxia or hypoxia, hypoglycemia, and hyperthermia. So maintaining physiologic norms during the perioperative period is key and something that we can do now to try to lessen the neurological injury in our patients. And to promote some of the work that our colleagues in Europe they've had this Safe Thoughts initiative, and you can look up their initiative in this website, safethoughts.org, that was established to emphasize the role of the conduct of anesthesia to provide high quality anesthesia. That is in this checklist, as you know, checklists are very, very in fashion now. So no fear, no awareness, normal volemia, normal tension, normal heart rate, normoxia, normal capnia, normal natremia, normal glycemia, normothermia, and no postoperative discomfort. If we cover all of these, we should be able to get some of our patients through and make sure that we're doing the best we can given our less than full understanding of this process. So I'd like to close by saying that indeed the issue here is the patient itself. This is a nice model that my dear friend and colleague Ruth Graham put out, where there's this diathesis stress dual risk model of the resilient patient or the vulnerable patient. Hopefully most of our patients are resilient, are able to tolerate the impact of that occurs during the perioperative period. And no matter what the experience are, both positive or negative, they'll fly through with a good outcome. However, we have vulnerable patients that also are in the mix. And certainly when they come in the perioperative period, they will have negative outcomes due to the environment, changes in the anesthetic drugs, the surgery itself, and postoperative period, whether or not they have a lot of pain and such, or have delirium post-op. So certainly congenital anomalies and prematurity play a huge role in this impact in this area, particularly in identifying vulnerable patients, but also prolonged surgery, anesthesia, and hospitalization is something that we should note that can occur. So in closing, in looking for the phenomenon that explains this issue of anesthetic-induced neurotoxicity in pediatric patients, Andrew and Laszlo conclude that so far there's no coherent phenom for an association between surgery and anesthesia in children and adverse effects in the neurodevelopmental domains. Well, thank you very much again for listening to this this area of investigation that we all have quite a huge stakehold in, and I look forward to listening to your questions. Thank you.